What's going on, everyone? Welcome back to Beyond Adjustments. This is season 2, episode 2, and part 2 with Dr. Lee. And this one goes deep. In part 1, we talk philosophy, practicing from kind of the inside out. But in part 2, we step into precision. We break down upper cervical decision making, when shockwave, cold laser, truly serve healing, who's actually a candidate for decompression and who isn't, etc. But what I really loved about this conversation is about maturity. It's about restraint. It's about evolving from doing more, watch this, to doing better. If you're a chiropractor growing into that next level of clarity in your practice, this episode's for you. Let's get into part 2. One thing I really respect about your practice now is how intentional you are, and it sounds like you're really intentional with tools as well. You mentioned
Sure.
shockwave, you mentioned cold laser, right? So what I'll ask it this way: what tissue states make you think shockwave versus laser?
I would, right off the top of my head, Shockwave, the short time I've studied and implemented it, patients have a much better response when they're in a chronic phase. So, old injury, 6 months or older, having the opportunity for scarific tissue to build. The way it works, it helps break some of those fibers and adhesive tissues up so that the body can go in and clean up and lay them down in much smoother fashion, which minimizes the chance of further injury, increases range of motion. The cold laser I use in a little bit more acute injuries and patients. It has a phenomenal way. I'm trying to search for the word, but it stimulates mitochondrial productivity, so it increases the amount of energy that cells are producing. They're already needing to produce more when they're in acute phase. They're swelling in the area, so there are some studies that show it releases erythropoietin, increases blood flow, can kind of flush some of that acute swelling out without increasing the inflammatory process. On the chronic side with laser, I see it works a little bit more in chronic neurological conditions. So, peripheral neuropathy, diabetic neuropathy, things of those nature. Somebody that's got some foot drop, using the laser on there will allow some quickening of that neurological healing, and get some sensory return and some mechanical strength through a neurological approach as well.
How do these modalities, specifically the couple you just mentioned, change healing timelines if used correctly, of course?
Sure. It does speed healing up quite a bit. So it allows for patients to go through. Motion is lotion, right? That's what I do is I work with patients aberrant motion to restore their nervous system to homeostasis. This allows us to minimize the swelling, increase the healing, so that motion can be built into a new normal motion pattern or movement pattern, and neurologically they respond quicker when that motion comes back, more normal, more quickly.
Now, I've seen this. If I've seen it, I know you have. But where do you see clinicians misuse or overuse them?
If it's in the office, a clinician will feel justified in its use. These are cash modalities. I see all over the Insta tweets all day, every day. I want to practice. You need to buy this. It'll add $10 million per week to your. Yeah, it will, but is it what the patient needs?
Right.
I'm not going to go in with a patient that has a sprained AC joint and put shockwave on it. They will talk ugly about me and my mama. It is the wrong modality, and just because I have it does not mean that's what that patient needs. So, vetting a patient appropriately. Had a gentleman come in this morning that wanted shockwave. And I said, well, the first thing we're going to do is we're going to check you out, see if you're a candidate for shockwave. And if you're not, I'll talk to you about what we can do. he actually ended up, he had had some ACL surgeries, 2 of them most recently in 2008. So yes, he had a chronic condition. He's recently started playing pickleball and squash and tennis again. So he wanted to make sure his knee was moving properly and all that stuff. So he was a candidate for Shockwave.
Gotcha.
So
How do you prevent, if possible, these kind of, I would call advanced therapies from becoming shortcuts instead of really complements to healing?
that is a great question. I don't start patients off just on that the majority of the time. Again, he sought us out for that because he had talked with his orthopedist who recommended Shockwave. We're one of the few in the area. The other ones are morbidly expensive to go have the same modality done. His wife has actually had great relief from that same modality. So he thought he would give it a try. At which case, yeah, we'll let him give it a try. I don't necessarily preventative knee issues on an old surgically invasive or surgically involved knee. Chiropractic's not going to do a ton for that knee, but the Shockwave was one of the first lines of modality we would use. When we get his knee feeling better and he's playing a little bit more, then we can do some patient education and say, hey, let's give that nervous system a tune up. Let's get you adjusted. At which time, again, we will have talked with him. He might have a massage or some acupuncture as well, if he wants to make this kind of his wellness shop. But meet him where he's at, allow him to feel what we can do from a relief standpoint, and then build that trust with him.
In short, really, for any of the DCs listening right now, just because you can use it doesn't mean you should. So just putting that out there, take the advice from Dr. Lee, been in the business for over 20 years. So,
sure. And that, I have a digital x-ray unit in the back of this clinic, and I'm not going to use it. I did not use the x-ray unit in my previous clinic for 15 years. I had a great working relationship with the imaging center. But when I did have an x-ray unit, 90% of my patients that came in got x-rays. And it was a part of the vetting. I learned how through examination to vet further, to build a much stronger history and consultation and a much stronger examination that disallowed me to lean on x-ray quite as much, or allowed me to not lean on x-ray as much. So, same concept there. If it's in the office, you feel justified in its use.
Yeah. And I feel like it's the patient type as well, right? Like you have someone, so as you know, my kids have scoliosis. So in that situation, especially if we're under like, an intensive of some sort, we want to see progress. So yeah, x-rays make sense, right? But because we want to see degrees and what have you. But I love what you're saying there. Like just because you have that x-ray machine doesn't necessarily mean, and you might, let's say if you're starting off, right? Fresh DCs, new practice, don't really have the experience that you have, might need to use it a little more. But if you get to the point where you can, again, like further examine, like you're saying, why not? Like, why even use the equipment if it's not needed? So,
Sure. And two, you mentioned that earlier, what would a young me have? I would have let ego get in the way. At this point, if a patient has a red flag and needs an x-ray, I am extremely comfortable in looking them in the eyes and saying, you need to leave my office and go get an x-ray. Whereas a young me would have been like, oh, well, maybe I can treat you without it. You're already here. No, if you need an x-ray, you will have an x-ray before I treat you, period. I don't have it in my office, so here's where I send patients, and that comes, that's an experiential confidence as well, that on the flip side of that, just because I don't have one does not mean that I don't get them when patients do need x-rays or MRIs or what have you.
No, that makes sense. And I think that same restraint and knowledge and experience is going to show up with other modalities like decompression, for
Oh,
example,
absolutely.
right? So,
Sure. Sure.
spinal decompression is also becoming a thing. Chiropractors are buying the tables, which is great because decompression is awesome, but it's another situation where you really need to determine who's a good candidate for decompression and who isn't. How would
Yes,
you
sir.
actually do that though?
Very, very similar. The examination process I do, I learned from through our primary spine practitioner certification up at University of Pittsburgh that helps you drill down to what the pain generator is in lumbar pain. So is it discogenic? Is it a joint dysfunction? Is it a true radiculopathy? Is there a myofascial component? Yes, there is most of the time, but is it primary? Or is it psychosocial? So from those 5 pain generators, you vet through, find out, and prioritize. And then you bring in the history of long history of back pain. They've had X-rays or MRIs, and it shows a degenerative disc or a bulge or what have you on some of the other modalities. Um, and then it still comes down to a 2-week trial of
Mhm.
care. I think you'd be a great candidate for decompression. You're not in your acute phase. You're not killed over in pain. So we can put you on there without fear of having to bring you up after decompressing someone. If they're really acute, you've got to be very careful bringing them up, or boom, things clamp back
Mhm.
down. So it's a little bit more subacute subacute or chronic type patient that I would focus in on. Um, Age of the patient, you know, do you want to put a 7-year-old on decomp? Probably not. Do you want to put an 85 or 90-year-old on decomp? They're probably got some osteoporosis in there. Most of that disc tissue is desiccated, so it's probably not a disc
Mhm.
primary. And if it is, when you're cranking down, if they're osteoporotic, you got a chance of damaging
Yeah.
stuff. Um, yeah, just kind of vetting it
Sure.
out. Morbidly obese people actually are not the greatest candidates for decompression in my
Mhm.
experience. It's hard to get a good cinch on the wraps, the thoracic and pelvic wrap. And laying them down is these decompressive by nature. So something like a flexion distraction or a abdominal swing away, put them on a table with a removable abdominal piece, and kind of slowly allow that disc to creep as opposed to, be pulled on. It has a really good effect.
What's actually happening neurologically or biomechanically during decompression?
So biomechanically, the slow, sustained pull through the initial phases of decompression allow you to kind of go past stretching the muscle. The muscle typically, if you pull against the muscle, it pulls back. If it's a slow, it's kind of like the um, um, lobster in a boiling pot. If you put them in a boiling pot, they jump and they click. But if you put them in cold water and bring the heat up, slowly they cook. Well, that's the same thing with a disc. If you slowly bring it up, the muscles
Mm,
readapt to their
that
new
makes sense.
length over the amount of decompression. Then there's an oscillation. So in order for it to be called spinal axial decompression, there has to be an oscillation at the upper ends of that. You can have a sustained hold, but there needs to be some oscillation to allow imbibition in that discal
Like
material.
breathing.
So if a disc is squishing, if bone and bone are squishing on a disc and it's ballooning out on the side, and you decrease the pressure by increasing the space between those, everything comes in. And if you do it real slow and gently back and forth, the disc is almost avascular tissue. So you need to imbibe, you need to pump good nutrients in, you need to flush some of the old
Yeah.
nasty out. That slow change in tension and pressure allows those often brittle or hardened tissues to loosen up a little bit as well. Not to mention, if there's pressure from that bulge kicking out and hitting a nerve, you take some of that pressure off that nerve, it can start to function, leading to, more
Yeah.
appropriate neurology, less pain. I've had folks get off a decomp and they all of a sudden can bear weight on a
Wow.
leg. because you took the pressure off the mechanical aspect of that nerve that was being pinched on.
Yeah.
So really, really great modality. It can be, I've given quite a few trials on patients who are in their last stitch effort. Injections hadn't worked. You know, they've got surgery scheduled, but it's 5 months down the road before they can get the surgery done. Like, listen, we will try. I'll start real slow and see if we can ease you into feeling better until had one patient that got so good they ended up canceling the surgery. And that's not everybody, but again, trying to increase the life that they can live while they're waiting is it's sometimes that's all we can do.
You said a key word during your explanation. You said the word slow or slowly. How do you how do you talk to patients who want like really fast results? We're in an Amazon age. Like everything is overnight prime, like yesterday. Like if I don't get my package 2 hours after I order it, I'm like itching, right? That's the
Sure.
that's the temperature that we're living in right now. But
That's good old 21st century way.
How do you talk to patients who want their Amazon package yesterday? If this conversation is hitting for you, make sure you're subscribed and send this episode to another chiropractor who's ready to level up. Now, back to Dr. Lee.
A lot of times I can correlate these conversations with how long they've been dealing with it already. The majority of folks who push and push and push and want it they have been dealing with it for so freaking long. They're pulling their hair out. They're like, it's gotta be better. I've been dealing with this forever. Well, now that we're finally doing something about it, picture every time you had an episode of back pain, picture a layer of building up, an onion, if you will. You can't get to the outside layer of an onion and expect to all of a sudden show up to the core of that thing where the sweet meat is. You're going to have to peel back some of those layers, and it's going to take time. If you go to a surgeon, guess what? They cut you open, they cut that off. But guess what? You still have 6 to 8 months of healing that you've got to go through. They don't cut you loose. They'll still put you on restrictions forever if you want them to, or if they need to. So it's not like I can do that without a surgical blade and have any quicker approach to that. It's physiology. And I've got Guyton's physiology laying right in there on the counter, and I'll go to them and say, hey, tissue healing takes time. It's principle number 6 in the green books. I can show them that too. Most folks intuitively know that, but they are, kind of at wit's end when they've been in pain for a long time and they've kind of swept it under the rug. Well, all of a sudden the rug's lumpy and they got guests coming over. It doesn't compute. So you have to talk folks off the edge every once in a while.
I think that those kind of conversations and that kind of decision making really comes with time. You're again speaking from a place of 20 plus years experience, and so I mean, early in practice, did you feel pressure to do more, would you say?
Absolutely. And I think too, we're health care givers, give care. By definition, we got into these professions in healthcare to actually help people. So we want to help people. And with the 21st century mentality and a good old American way, if one is good, 8 is better. Not necessarily the case when it comes to physiology and healing. So I've got all these modalities. I can make a lot more money if I used all these modalities all day, every day. But is that what's my mission for helping people? No. I want to get people healthy. I want to do it in a good old natural way, what I refer to as a commonsensical way. And I want to put things together so that we're doing just enough to have it's a sweet spot. I want to do just enough to get them where they need to be in as short a period of time as naturally
Yeah.
possible. You can take steroids and put a lot of muscle on, but you're not actually strong, kind of thing. So I want to have a nice
Sure.
balance,
Yeah.
and that's where my patient education has kind of shifted over to. It's like, hey, this is what you got going
Mm-hmm.
on. This is about how long it's going to take. These are some things that I think would help you in that journey, be it a massage, acupuncture, shockwave, whatever we've got here. Um, Also, do you have a good diet? You
Mm-hmm.
know, and I know a nutritionist and a dietitian in town here. Are you open to having some psychosocial counseling type
Mm-hmm.
feedback so that this is not how you constantly walk around,
Mm-hmm.
because this adds to your neck pain and your
Right.
headache. So, giving them those
Sure.
options, and allowing them to heal up in a natural
Yeah.
manner, is kind of where I'm
Yeah.
focused.
And again, that's a place of maturity, right? I think at least it you didn't get there overnight. For those young DCs that feel like they might not be doing it that way, that's okay, right? But take this as as like when I talk to my kids, I'm like, I'm telling you this is not going to work, right? But they're going to do it anyway.
Sure.
So in
And that's, I was doing this. This is where all the gray
yeah.
came from in my beard. I mean, I've got, it's having those conversations, and
Yep,
I've had them 1,000 times myself, but it's very meaningful to the person that I'm
for
having it.
sure.
I've not had that conversation with that person as many times as I've had
Right.
it. And your children are a little younger than mine. So my children are all young adults now, and raising a young adult is substantially different. I've got to be able to be real sharp and real quick and put an idea out there and make them think it's theirs. That is the right thing to
Mhm.
do. And then just support and say, gosh, you're a genius. How did you come up with that?
That's
you
that's
know,
good
and
tactic right there. That's awesome.
it's the same. It is literally the same thing with patient care. It really is. If you can be a wonderful provider, you can be a wonderful parent, and vice versa.
Yeah. Yeah,
Um,
yeah. Let me
yeah.
ask you a tuck clinic versus intrinsic comparison question, right? So how, if it has, and I'm going to assume it has, again, because you're running your own practice, you're going to do things that you probably didn't do before
Sure.
because you had to follow certain policies, and that of course makes sense because it's one company, right? But how has that shift, right, change how often you choose not to intervene, or has it?
I don't know that it has
Okay.
yet. I've only been here about 3 months,
Hey, 3 months is a lifetime for some
but I
people.
do think I have had. I take that back. I have had one patient that came in that wanted an adjustment, and it was like, listen, today might not be the day for an adjustment. I don't want to put you into a bad spot. They were going on a trip, and I feared that they would have a lot of discomfort and or pain afterwards. One of our massage therapists was able to give them a 30-minute massage instead. So that's I'm out of I'm out of a role in my previous employ, where I was a tenured doctor that had been there. I had written and been a part of writing a lot of the systems, and there was very little room for wiggle through those systems. Even if my experience dictated that I could wiggle that room, now I don't have those rigid, firm boundaries. I don't have any younger doctors looking up to me saying, "Oh, but Mathis did this." I don't have to justify my moves to anybody except to the patient.
Hmm.
I can have that conversation right then and
Hmm.
there. So, um,
Yeah.
I don't know that it's right either way or the other. It was, and now it is. And so I'm kind of getting used to and getting normal to that as well.
Gotcha. Um, so I want you to talk to the younger chiropractors for a second, because
Sure.
they're gonna make mistakes, right? And maybe
Mhm.
not from incompetence, um, but good intentions, right? What would you say to those chiropractors?
Sure. Fail forward. realize that it is not the end of the world. Somebody else has made that mistake before. And I'm a big fan of owning it. You know, if I do something and it's not the right thing to do, mea culpa. I'm going to apologize to anybody that I may have upset or harmed. I'm going to do the best I can to right that. I'm going to put that in the back of my head and say, all right, you know, you don't have to kick this dog twice. We can learn from that first mistake. Um, I had this. This is one of the beautiful parts of working in a group for as long as I did. I had mentors at my fingertips. I could call. I could walk down one of our other drive over to one of our other clinics. Our state association worked like that as well, and it will again as next year pans out and rolls out, and I become more involved with our state association. You know, we are all in this together, and everybody, you're not going to do anything that somebody else has not already done. So read up on those. NICNIC has a beautiful, they send out these monthly or quarterly newsletters, and there are cases you can learn from. Learn from those. By all means, listen to podcasts like this. People they'll give you little nuggets that keep you from slipping up in a way that was unintentional, or help you correct something that you need to do and intentionally you might not be doing to the letter of the law or what have you. So yeah, that too comes from kind of letting that ego step out of the way, and not having to do it all y'all. Lean on others that have been there before.
And sometimes it's okay to do less, but do it better. And then build from there.
I have, and I hope this is okay, but I've told folks that I'm working on becoming a master of one instead of a jackass of all trades. And I'm also working on becoming a jackass of all trades and less of a master of one.
Love it. Love it.
So it is this neat little balance of
medium.
know what you're good at, know where your comfort level and your sweet spot is, and focus on that, with the understanding that, you know, somebody comes in that's a pediatric patient, and I don't do tons of pediatrics, but I've got 3 kids. I've treated them forever. You know, I can take care of those children. I can also take care of sports athletes and this, that, and the other. So I do the best I can for the patient that's there. The longer you do it, the more of a click you will build, a niche. Folks will start being attracted to you, that you can help the best. It's pretty awesome.
I love that. Couple closing questions here for you. What's one thing patients can start doing today to live more intrinsically? Yeah, I did it.
Did very, very nice. We're 70 to 72% water. I would say drink more water. You've seen me tipping my cup up the whole time here. That's one of those things that has kind of been a sounding bell for me a lot of my career. Used to have a little sign on our water cooler in my old office that said, drink all the water, pee all the time. Hydration is massively important for every metabolic function that happens. And when you drink more water and you have to use the restroom, you have to get up and move. And so that keeps you from sitting at your desk or in your truck or wherever you've got to be for work. So I would definitely say drink more water.
That's awesome. I'm guilty of not doing that. Although I do try to finish one of these a day. That's always my goal.
I had a backup just in case my cup ran out.
So. I gotta follow that advice myself. What would you like? Give me one thing that chiropractors should stop doing immediately, Dr. Lee.
Oh man. I'm gonna go straight to your world. Stop doing cheese ass marketing by showing the biggest pop and snatching people with. Guys, what we do is not a parlor trick. This is something that should be held to a very high esteem and done in a very reverent manner when it is appropriate to do. Our bad rap continues to be our bad rap because we're our own biggest We hang ourselves all the time. This
Yeah.
biggest pop, biggest crack. That's
Yeah.
yeah. Because if
TikTok
you do it different
chiropractors.
with somebody that comes
Yeah.
in, don't come on. You're cheapening us.
Yeah.
We
Yeah.
are out here trying to make an impact in people's lives, and
Yeah.
you're cheapening us. That's not. I wish other chiropractors would stop trying to cheapen what I'm trying to do.
Yeah. I preach it. I
Because if they don't, I'm gonna hunt them down. Let me tell you, I'm from the swamps and we deal with it different.
you use your shockwave
Oh
is what you're
mercy!
saying. That's what you're yeah.
That's what
Yeah.
I'm
You
gonna
use
do. I'm gonna laze them, and then I'm gonna
shockwave.
shockwave
Yeah.
them.
All right. I'll leave you with this last question, Dr. Lee. What excites you the most about this chapter at Intrinsic?
Oh
Yeah.
wow. Um, I'm extremely, extremely excited about the potential to implement some things across and kind of through an interprofessional manner that I've learned at Tuck, that I've read about and dreamed about. Kind of all the stops can kind of get pulled now, in some really neat, um, futuristic healthcare type models. Now that I'm kind of doing my own thing, and I don't have tons of folks looking up to me, I can make some mistakes as
Mm,
necessary to improve what healthcare can be, in this region, and hopefully scale that out. Um, Interprofessional, collaborative type models of care. One of the really exciting things that I think that our group can offer, Central Virginia at least, is a ease on the burden of
mm,
healthcare, providers. UVA does not just serve the demographics of you know Central Virginia. UVA is a teaching hospital. It is a world-renowned research facility, and folks come from
mm,
everywhere. And I did not realize, I have patients in Southwest Virginia who would come up here for allergy shots or neurological stuff. I had a patient come in this week from Christiansburg who was up here for some neuro-optometry
mm,
work, and came by for an
mm,
adjustment. Um, but that has really bogged down the potential of having expedited healthcare.
mm.
If I need a patient to go to an orthopod, they're going to go to the orthopedic group that I went, the independent orthopedic group that I went and met at lunch today. Um, I'm working hard to introduce myself and our team to other providers,
That's
so
great.
that as their backlog continues to grow, like it does in a large metropolitan
Hmm.
area, we can hopefully build a working relationship where we can ease their burden.
Hmm.
Hey, this patient they're not going to get your injections. They're not going to get your surgery. Send them to us and let us work with
Hmm.
them, to hopefully get them better. But if at which time they do need your services, we'll kick them right back to you, kind of thing. So that's the potential, and exciting potential of what Intrinsic Wellness Collective is. We're kicking off here in our first chapter. Um, so yeah.
I wasn't gonna ask you this, but I'm going to
Uh-oh.
anyway. Because
Okay.
this is a hard, like, I wouldn't know how to answer this, but I'm gonna put you on the spot. Like, if you asked me this question,
Thanks.
I'd be like, thanks. So I don't know what what's gonna come of this question. But when you look back at this moment, 5 years from now, what do you think you'll realize this chapter gave you? I and I phrased it in that manner because it's what we hope or what we're like.
Sure.
So what like look back. We're 5 years from now. Jesus hadn't come back yet, and you're
Yeah.
you're looking back and what do you think you'll realize this chapter gave you?
I think it will give me the oh my word, what a
Right? Yeah.
question,
So
sir.
I
What a
wasn't
question.
going to, but I'm like, you know what? I'm gonna ask it.
Yeah, no, that's a great question. I think I'd answer that by saying, the self-confidence that what I'm doing now will give me 5 years down the road. I'm not coming out of the gate swinging and marketing everywhere. I'm not doing that. I have a very meager practice that, I inherited. Um, I'm looking to triple that at some
Yeah.
point. Is kind of the capacity I want to be at. But I'm taking what I consider an extremely slow approach to make sure that the systems we put into place, the things that we do, I want to start out like I can hold out and grow as I need to. But I want to make sure that what we're doing is foundational for what I want to do. I'm going completely against the grain of my nature, and I'm not going after the big, shiny, fancy, tinsely thing. I'm really trying to settle in and build a real strong foundation that will hold whatever else comes next. And I think 5 years from now, I'm going to look back and be very, very, very excited about myself for having the insight to just take my time, which is, like I said, is very, very not Lee. But it's a new chapter, so I'm going to breathe into it and see that my marriage, my wife and I are finally married now after all these years. There's no kids. We've been married the whole time, but
I
we don't
got
have
you.
kids.
Yeah, I got you.
Know that my children are utmost priority, and if they need me, I can get there, and that I'm building a professional life that is supportive of that. 5 years down the road, that's going to be very exciting to look back and say, he listened. He read a lot of books. He actually did what he had seen modeled out for him. He did what his mentors and counselors and all the research had told him to do. And good for him.
Yeah.
He was a smart young man back there at 45.
That's awesome. That's awesome. All right. Well, I appreciate your time. I thank you again so much for taking the time to come on here and help us launch season 2. Very exciting. Dr. Lee, thank you so much.
That is so awesome. Congrats. I mean, thank you. As always, this is a blast. I love chewing the fat and shooting back and forth with you. This is really, really good stuff.
Yes, sir.
So thank you.
Yes, sir. And congratulations again on the new practice.
Thanks. I appreciate it.
That is season 2 energy right there. Not louder, smarter, more precise. And Dr. Lee talked about discernment, about choosing not to intervene when it's not necessary, about building capacity instead of chasing symptoms. That's growth, right? So if you're a chiropractor, ask yourself, where can I refine instead of expand? If you're a patient, ask yourself, where can I trust the process instead of rushing? This is Beyond Adjustments, where we go beyond the adjustment into the mindset behind it. I'm Amin Saeed, and I'll see you in the next one.